All right, everyone awake and ready to keep going? Just three more sessions. They're all going to be a lot of question format, so hopefully a little easier content as well. The development stuff is tough. All right, so we're going to talk about immunizations. You're only giving me 17 minutes? Oh, there you go. Okay, thank you. Okay, so we're going to talk about composition, indications, contraindications, and adverse events, okay? I would not get very caught up for the purposes of the boards looking at vaccine schedules because, as you know, those change all the time, so they can't possibly ask you schedule-type questions except very, very basic schedule-type questions, which we will review. But I've included these just so you have them in your handout. All right, so just a couple of principles we need to talk about. You never need to start over an immunization series. Remember that there are upper age limits for selected vaccinations, especially the Hib vaccine is 59 months. Unless you're immunocompromised, you may want to give it after that. The DTaP, 6 years, 11 months. Beyond that, you want to give Tdap instead. And PCV13, the upper limit, like with Hib, is 59 months again, unless you are high risk. And then you also may need to give a reduced number of vaccines. For example, for Hib vaccine, you only need to give 2 doses if you start the series at between 12 and 14 months, and only 1 dose if between 15 and 59 months. This is for catch-up immunization. For IPV, if you give the 3rd dose after the 4th birthday, you don't need to give a 4th dose. And for DTaP, if the 4th dose is given after the 4th birthday, there's no 5th dose needed, okay? So those are just some quick things to keep in mind. You also want to know the non-contraindications for any vaccine, okay? So certainly breastfeeding or pregnancy in a household contact. If you have someone with a mild illness without fever, even if you have fever, unless there are signs of moderate or severe illness, that's not a contraindication to giving a vaccine. Certainly chronic diseases without immunosuppression. Somebody on antibiotics therapy can generally be vaccinated with the exception of oral typhoid vaccine because it may actually kill the oral typhoid bacteria that's in there. Immune deficient household contacts. So if you have someone in the household who is immune deficient, you can generally give all vaccines with the exception of smallpox, which we don't routinely give, and OPV, which we no longer give in this country, okay? So with chickenpox vaccine, we always get a lot of questions about that. Even though this is a live attenuated vaccine, there is only transmission if the person getting the vaccine develops the rash, in which case they want to avoid contact. But that is not a contraindication because the rash from the vaccine is so rare and transmission appears to be very limited. And then with the live influenza vaccine, the only time you need to take precaution is if you have a severely immunocompromised contact, such as somebody who's recently had a bone marrow transplant and is in isolation, okay? So really, smallpox and OPV are the only ones you have to remember. And I've listed here a whole bunch of non-contraindications, which I'm sure you are all familiar with, but tend to pop up. Certainly personal or family history of seizures, family history of unexpected death, or family history of adverse effect following immunization. All right, so there are some guidelines for spacing of live and inactivated antigen vaccines. So anytime you are giving 2 or more inactivated vaccines, there is no recommended minimum interval between the 2 doses. So you can give inactivated vaccines, 2 of them at any time without there needing to be an interval of time in between. There are 2 exceptions which I'll talk about. If you're giving an inactivated and a live vaccine, again, there is no minimal interval between doses. The thing to remember is if you're giving 2 or more live vaccines, Unless you're giving them simultaneously on the same day, you need to wait 28-day minimum because they may interfere with the immune response to each other. For example, if you're giving MMR and Varicella vaccines and for whatever reason you don't give them on the same day, then you need to wait 28 days at least between giving them. The exceptions are the oral live vaccines, such as oral typhoid, OPV, and oral rota. You don't need to wait on those, okay? So the two exceptions for killed vaccines are the immune response to Menactra, which is MCV4D, because it carries a diphtheria toxin carrier protein. That response can interfere with PCV13. So it should not be given until at least 4 weeks after all doses of PCV13 have been administered. So in the second year of life, when you may give Menactra to a high-risk individual, you don't want to give Menactra during the second year of life because they're also going to be getting PCV13 during that time. So during that time, you need to use another meningococcal vaccine if they need it. And then you don't want to give PCV13 and the 23-valent pneumococcal vaccine, the Pneumovax, together. Those need to be spaced at least 8 weeks apart. And when both of them are indicated, you always want to give PCV13, the conjugated vaccine, first, if possible. Okay? All right. So as you know, pertussis vaccines today are acellular in nature, unlike the previous whole cell vaccines, which contained inactivated pertussis containing multiple antigens and contained endotoxin, which were probably responsible for the adverse effects that we used to see with whole cell vaccine. The acellular vaccine contained one or more immunogens which are derived from the bacteria but do not contain endotoxin and therefore are much less reactogenic than whole cell vaccine. They don't tend to be, recent data has shown them to be less efficacious than whole cell vaccine, but because they are much less reactogenic, that is what we use. All right, so let's do a question. Which of the following is an absolute contraindication to pertussis vaccination? Fever to 41 following a previous dose, a hypotonic episode within 48 hours of a previous dose, inconsolable crying for 3 hours following a previous dose, severe unexplained encephalopathy following a previous dose, or seizure without fever occurring within 3 days. Which of these is the absolute contraindication? Okay, very good. So D, severe unexplained encephalopathy. So let's just spend a couple of minutes talking about adverse effects from pertussis. So by far most common is erythema, swelling, and pain at the injection site. They can get entire limb swelling after the 4th or 5th dose, but even if they get this, this is not a contraindication for future doses. Fever tends to be low grade, especially with the acellular vaccines. Rarely can you get anaphylaxis and allergic reactions. Most seizures are febrile seizures and are not associated with long-term sequelae. The hypotonic hyporesponsiveness episodes that we used to see more commonly with whole cell vaccine are not associated with long-term sequelae, and the persistent inconsolable crying also is not associated with long-term sequelae. So the only contraindications are an immediate anaphylactic reaction, in which case you want to refer to an allergist for evaluation and possible desensitization, or encephalopathy within 7 days, which is defined as a severe acute CNS disorder which is not explained. And in those situations, diphtheria, tetanus immunization should be substituted for subsequent doses. The following are now precautions rather than contraindications. I won't read these to you, but certainly seizures, the crying that we talked about, collapse or shock-like state, high fevers, Guillain-Barré, these are all precautions. Remember that if you're dealing with a progressive neurologic disorder, you want to defer vaccination until the condition has stabilized. But with stable conditions such as a history of seizures, CP, developmental delay, you can go ahead and vaccinate, since These are stable neurologic disorders rather than progressive. All right, so the parents of a healthy 5-year-old are seeking your advice regarding the need for additional measles vaccination for their son. The child received 1 dose of MMR at 12 months. You appropriately informed them that he should receive a 2nd dose. Of the following, the most important reason to recommend a 2nd dose for this child is to prevent waning immunity. 5% of children fail to respond to 1 dose. Lack of cell-mediated immunity at 12 months. To induce an anamnestic response or to induce intestinal immunity. Why do we give a 2nd dose of MMR? Okay, very good. So the right answer is B. 5% of children do not respond to 1 dose of MMR. So that's going to leave 5% of children vulnerable to measles, and those kids tend to respond very well to a 2nd dose. So if we give everyone 2 doses of MMR, 99+% will be protected against measles. So a couple of words here. This is a live attenuated whole virus vaccine, which is grown in chick embryo cell culture. Again, about 95% develop immunity after 1 dose when it's given at 12 to 15 months. And the 2-dose schedule is to capture the 5% who have primary vaccine failure. Remember that you can give the 2nd dose of MMR at any time as long as it's 28 days after the 1st dose. We generally give it at between 4 to 6 years of age only for convenience, because that is when they are being seen. But if you have another reason to give it before then, it is perfectly acceptable, such as travel to a place where there is measles. You want to make sure that they've had 2 doses of measles vaccine before that. So remember that measles outbreaks back in the 80s and early 90s were due to delay in immunization of preschool children. However, today, most cases of measles are because of under-immunization, and most cases are imported. So someone goes overseas and brings back measles into this country, and because we have children who are vulnerable to measles, that's how we get into outbreaks. We don't vaccinate children before 12 months of age because this is associated with a higher primary vaccine failure, likely because of the presence of maternal antibody and other humoral immune deficiencies. However, in epidemic situations, it is recommended that you can give the vaccine as early as 6 months of age, but you don't count that in the immunization series. So if you give MMR vaccine prior to 12 months, that does not count, and they would still need 2 doses of MMR vaccine beyond 12 months. And the most common time that we do this, again, let's say that you had a 9-month-old who was traveling to a measles endemic area. You would go ahead and give them MMR prior to travel, and then once they came back, they would need the normal 2-dose series of MMR. Adverse effects from measles vaccine, they can certainly get high fever. About 5 to 15% do. This is usually 1 to 2 weeks after vaccination. So this is not within 48 or 72 hours. It's 1 to 2 weeks after vaccination, and they can actually have a transient measles-like rash as well. Transient thrombocytopenia is common. The risk of encephalitis with measles vaccine is 1 per 1 million doses. This is as compared to 1 in 1,000 doses, or 1 in 1,000 cases of natural measles. And hypersensitivity reactions are rare and are usually related to the components in the vaccine, such as neomycin and gelatin. As you all know, there is no causal relationship between measles vaccine and autism or inflammatory bowel disease. Question 3, whom of the following individuals should not be vaccinated with MMR vaccine? An asymptomatic 12-month-old boy with HIV who has a CD4 percentage of 25%, a 15-month-old whose brother has acute lymphocytic leukemia and is undergoing induction chemo, 12-month-old with a history of anaphylaxis to egg ingestion, 15-month-old who had Kawasaki disease at 12 months of age and received IVIG, or a 9-month-old traveling to Southeast Asia. So who should not receive MMR vaccine? I've already given you a couple of clues as to the answer to this one. All right, very good. So the child who has received IVIG, there is an interval of time after IVIG in which you can give live virus vaccines, and we'll review this. So these are the contraindications. Certainly anaphylactic reactions to neomycin or gelatin, moderate to severe illness. Altered immune status is generally a contraindication. The one exception is HIV, which I'll talk about. The receipt of corticosteroids, and we usually define that by 2 per kilo per day or greater than 20 milligrams a day of prednisone. Pregnancy is a contraindication, and again, recent administration of immunoglobulin. HIV is a different story because there have been reports of severe and even fatal measles infection in patients with HIV, and there's only one report of a vaccine-associated measles pneumonia in a patient who was severely immune compromised. So the recommendation is that we go ahead and vaccinate children who are asymptomatic and who do not have severe immunosuppression, and that is defined by a CD4 of greater than 15%, okay? Egg allergy is not a contraindication. Most children who have egg allergies do very, very well, and you do not need to take any precautions with MMR vaccine and egg allergy. And this is the table taken right from the Red Book, which you need to know, which tells you the actual interval of time that you need to wait between the administration of an immune globulin product and the receipt of a live virus vaccine, such as MMR or varicella. So for things like tetanus immune globulin, it's 3 months. For Varizig, it's 5 months. The one that I would remember is Kawasaki is 11 months. Remember that palivizumab is a monoclonal antibody. This is not an immune globulin product, so there's no interference with live virus vaccine. And if somebody received immune globulin for travel, then you want to wait on giving a live virus vaccine, or you want to give the live virus vaccine 2 weeks prior to giving the immune globulin. What do we do with unimmunized household contacts of people with measles? So this is with measles exposure. The recommendation is to go ahead and give the vaccine within 72 hours, as well as give immune globulin within 6 hours. This is for household contacts of somebody with measles. Immune globulin is indicated for susceptible household or close contact, especially contacts younger than 1 year of age, because the vaccine may not work. Certainly pregnant women in whom the vaccine is contraindicated, anyone who's immunocompromised who may not respond to the vaccine. Immune globulin, however, is not indicated if somebody has already had 1 dose of vaccine at 12 months of age or older, unless they are immunocompromised. In that situation, you just go ahead and give the 2nd dose of measles vaccine upon exposure. For HIV-infected individuals, you can't presume that the vaccine is going to work because it may not take. So in those situations, you want to give immune globulin within 6 days of the exposure, regardless of the history of a previous vaccine. And again, in children 6 to 11 months who are in epidemic situations or prior to travel, they can go ahead and get measles or MMR vaccine, but then they need to be re-immunized again with 2 doses after 12 months of age. Okay? Moving on to Hep B. What is the best course of management for a term infant born to a mom whose Hep B surface antigen status is unknown? Would you give the first dose of Hep B vaccine sometime within the first 2 months? Would you give Hep B vaccine within 12 hours after birth? Test mom ASAP and then administer HBIG to the baby within 7 days of birth if mom's found to be positive? Would you give HBIG and the first dose of vaccine at 3 to 6 months of life? H-big alone within 12 hours of life, or Hep B vaccine and H-big within 12 hours of life. So when in doubt, always go with the longest answer, right? Okay, so if you really had to guess and you didn't know. So the correct answer is B. So in this situation, you don't know mom's status. So the baby's going to get Hep B vaccine anyway, so you want to give that as soon as possible, and that is about 90% protective, even if you don't give H-big. And then you can certainly test mom, and you can certainly get that back, usually within 24 to 48 hours. If it's positive, then at that point, the recommendation is to go ahead and give H-big, okay? So what do we do with Hep B for infants? Well, if mom's Hep B surface antigen is positive, then you want to give both Hep B vaccine and H-big as soon after birth as possible, certainly within 12 hours. If mom is known to be negative, then you still give hepatitis B at birth. And if you don't know mom's status, as we said, you go ahead and give vaccine and test mom, okay? So for babies born to Hep B surface antigen positive moms, there's no leeway here. You really want to give the first dose of vaccine right at birth. You want to give the second dose the day the baby turns 1 month of age, and the third dose right at 6 months of age, okay? And then what we do to see if the baby has become protected is you want to test the baby between 9 and 18 months of age for hepatitis B surface antibody as well as antigen, okay? And if the baby is negative for antibodies, then you want to re-immunize with 3 subsequent doses at 2-month intervals, and then retest after that. This is if mom is known to be positive. There's a special algorithm for babies less than 2 kilograms. If mom is positive, again, you go ahead and give the first dose right at birth, but we know that babies less than 2 kilos may not respond to hepatitis B vaccine right at birth. So we would subsequently dose them with 3 doses between 1 to 2 months, at 4 months and 6 months. If mom is negative, then there's a little leeway there. You can wait till the baby is 1 month of age or at discharge from the hospital, and then the baby gets 2 subsequent doses after that. And in a situation where you don't know mom's status, again, you go ahead and give vaccine right at birth, and then give 3 subsequent doses later on. Okay, so varicella vaccine is contraindicated for which of the following patients? A 12-month-old whose mom has taken chemo for lymphoma, 18-month-old boy whose mother is pregnant, child with asthma who has been taking 20 milligrams of prednisone daily for 14 days, 13-year-old healthy male with no history of varicella, or a 5-year-old with a history of anaphylaxis to eggs. Okay, so the child who has asthma taking 20 milligrams of prednisone. This is just like the rules for MMR. This is a live virus vaccine, so the contraindications are very similar. Intercurrent illness, immunocompromised children. The exception, again, is that you want to consider giving chickenpox vaccine to HIV patients if their CD4 count is 15% or greater. So pretty much the same rule as for MMR. And again, children receiving corticosteroids for 14 or more days. Again, 2 per kilo or 20 milligrams a day, that's the general rule. And you want to wait at least 1 month after stopping the prednisone before giving the live virus vaccines. Immune globulin administration within 5 months, you want to wait. And anaphylactic reactions, again, to gelatin, neomycin, and pregnancy, all are contraindication. This is just to remind you that in the immunization schedule, where vaccines that may be indicated depending on the medical situations for MMR and varicella, they are contraindicated during pregnancy and generally for immunocompromised individuals. But if the CD4 counts are 15% or greater, it is okay to go ahead and give them. Okay, the safety in healthy children, this is a very, very safe vaccine. About 1 to 3% will actually have a localized maculopapular or vesicular rash. It can become generalized in 3 to 5%, and this usually occurs 5 to 26 days after vaccination. There may be discomfort at the injection site. And again, remember that transmission of the vaccine virus to a susceptible contact has only been documented in very, very few cases. So this is thought to be a very rare event. So we don't take any precautions with varicella vaccine given, even when there are immunocompromised or pregnant people in the household. Which is a true statement regarding pneumococcal vaccine. Conjugate or 13-valent is indicated for all children starting at 2 years of age. 23-valent polysaccharide vaccine is not immunogenic in children less than 2. Children with congenital immunodeficiency should receive polysaccharide rather than conjugate pneumococcal vaccine, or polysaccharide pneumococcal vaccine is associated with significant adverse reactions as compared to conjugate vaccine. Okay, very good. So the reason we don't give the polysaccharide vaccine before 2 years of age is because it's not immunogenic. This is recommended for children 2 years and older who are at high risk for invasive pneumococcal disease, and this is generally tolerated very well. Whereas, as you know, the conjugate vaccine is indicated for all infants starting at 2 months of age, and this has resulted in significantly decreased incidence of invasive pneumococcal disease and a mild decrease in the incidence of otitis media. These are the risk groups for which we would consider pneumococcal polysaccharide vaccine at 2 years of age. Certainly immunocompetent children, children with who have chronic diseases such as chronic heart, lung, diabetes, CSF leaks, and cochlear implants. We would also give it for children with functional or anatomic asplenia and any immunocompromised child. So if you do have an immunocompromised or a sickler or an asplenic child, the recommendation is to give 1 dose of polysaccharide vaccine at the age of 2 years and at least 8 weeks after the last indicated PCV13, that should be. And then you would give 1 dose 5 years after as a booster dose. For immunocompetent children who have chronic diseases, they also get a dose of polysaccharide vaccine at age 2 or greater, and they do not need a booster dose following that. And then influenza vaccines. Inactivated vaccines are produced in embryonated eggs. They are usually whole virus or viral antigen vaccines that contain strains against both influenza A and B. They do contain residual egg proteins, and they are indicated for children and infants 6 months of age and older. Remember that the intranasal live attenuated vaccine is licensed for ages 2 to 49, but is not currently recommended. So I don't think they're going to ask you any questions about the live flu mist vaccine, but I'm going to go over it a little bit just in case. So let's talk about inactivated influenza vaccine. Local reactions are infrequent. Febrile reactions are also infrequent. These are very well tolerated. In some years, there has been a very loose association with Guillain-Barré syndrome, but there is no clear causal relationship. The only contraindication is really a history of severe allergic reaction to any component of the vaccine or to a previous dose of any influenza vaccine. And then a precaution, not a contraindication, but a precaution is a moderate to severe illness with or without fever and a history of Guillain-Barré within 6 weeks of receipt of a previous influenza vaccine. So where are we with egg allergy? This has changed over the past several years, so it's new enough that they may not ask you about this, but just know that ACIP and AAP basically say that any licensed, recommended, and appropriate inactivated vaccine can be given to anybody who has an egg allergy of any severity without any precautions. However, the product label, severe allergy to eggs, is listed as a contraindication on the product label of the inactivated as well as the live virus vaccine. So a couple of words about intranasal live vaccine. This is a cold-adapted vaccine, and it showed unexpected reduced efficacy in 2014 and 2015, especially against the H1N1 strain. So it used to be indicated for vaccination of healthy, non-pregnant individuals 2 to 49 years of age, but again is currently not indicated because of this. I've listed here the contraindications that you can look over. I'm not going to read them to you. And again, like with an activated vaccine, there are precautions as well. All right, so finally, remember that the immune responses in HIV-infected individuals are going to be generally diminished. You can presume that they're going to be diminished. The response does appear to correlate with CD4 count. That's why we generally use that 15% cutoff. So because immunity wanes with advanced disease, the recommendation for any HIV-infected individual, certainly on your board exam, if someone's exposed to Hep A or measles or chickenpox, regardless of their vaccination status, you should regard them as being susceptible, and you should give them immunoglobulin to protect them. And the last question, which should be an easy one, is which of the following virus vaccines is most likely to be transmitted to a susceptible household contact? Rubella, measles, varicella, vaccinia, or HPV? It should be 100%. Oh, it's not. Okay. Wow. Wow. Okay. So the right answer is D, vaccinia. Okay, so remember, rubella, measles, varicella, and certainly HPV, none of those are going to be transmitted to a household contact. Those viruses are not shed. Vaccinia is the smallpox vaccine. That and OPV are the ones that can be transmitted to household contacts. Okay, so remember, OPV, yes. Varicella, yeah, but very uncommon and only if they develop a rash. Vaccinia, yes. MMR, no. Live attenuated influenza vaccine, yes, but very uncommon, so that you only have to take precaution if the contact is a bone marrow transplant patient in an isolated environment. And rotavirus, yes, but also appears to be very uncommon, and we don't generally take any precautions in that situation. Okay, very good. I've included all the footnotes to the immunization schedule, just in case.